Welcome to today's webcast, which will provide you with an update on New York State's HIV testing law. I'd like to offer my thanks to the many administrators, healthcare providers, consumers, and advocates who helped us progress as far as we have. Since July 30th, 2010, the day that the HIV testing bill was signed into law, I've been involved in countless meetings with many of you as together we've paved the way for widespread implementation of the law. Over the last year and a half, the AIDS Institute has hosted regional stakeholder meetings, met with hospitals, discussed implementation with community health centers, held focus groups with pediatricians, collaborated closely with New York City and other health departments, and listened to consumers. We've heard from literally hundreds of individuals as we carefully crafted the regulations that were finalized and adopted on February 22nd of this year. The HIV testing law was enacted to make HIV testing a routine part of healthcare. Key components of the law include the required offer of an HIV test for individuals 13 to 64 years old, a simplified consent process for HIV testing, and the requirement to arrange for HIV care for patients with HIV-positive test results. In the process of developing these regulations, the Health Department has been able to address many of the barriers to HIV testing that providers have brought to our attention over the years. The providers featured on this webcast have developed practical, real-world strategies to make routine HIV testing available in their sites. You'll hear from a large urban emergency department, a community health center with multiple sites, and a busy upstate pediatric practice. I applaud them for their efforts as I applaud the many other forward-thinking providers and facilities that could have also been featured on this webcast. During this webcast, you will learn about a toolkit that the AIDS Institute has developed to help healthcare providers implement routine HIV testing. Over the last 2 years, the AIDS Institute has received hundreds of questions from the field, and we have updated our list of frequently asked questions with answers to these questions. You can find a link to these FAQs in the toolkit, and you'll find many resources to support HIV testing on the Department of Health's website. The adoption of the regulations this past February paved the way for full-scale implementation. At this point, the department expects that all parties addressed in the law have either implemented the mandated activities or made their technical assistance needs known to us. HIV testing has a central place in the National HIV/AIDS strategy. Our efforts at implementing the 2010 amended law are critical to achieving the three primary goals of the national strategy, which are reducing the number of people who become infected with HIV, increasing access to care and optimizing health outcomes for people living with HIV, and reducing HIV-related health disparities. Preliminarily, we have noted a 13% increase in New York State HIV laboratory testing levels since the law went into effect, but clearly there is still much work to be done. Thank you for joining us in this important effort. I hope you find this webcast useful.
Hello, and welcome to Public Health Live, the third Thursday breakfast broadcast. I'm Joyelle Ray Alexander, and I'll be your moderator today. Before we get started, I would like to ask that you please fill out your online evaluation at the end of the webcast. Continuing education credits are available after you take our short post test, and your feedback is helpful in planning future programs. We encourage you to let us know what topics are of interest to you and how we can best serve your needs. As for today's program, we will be taking your questions throughout the hour by email only. Please email us at any time throughout the hour at phlive.newyork@gmail.com. Additionally, the School of Public Health is excited to announce the development of a new companion guide for the Public Health Live program. The guide can be found on our website, phlive.org, and will provide guidance, discussion points, and learning activities for those looking to enhance their learning experience with our program. Please visit our website at phlive.org to download the guide for today's program. There's a section in the guide asking for audience feedback for how we can improve this product. We look forward to receiving your faxed or emailed comments or suggestions for this guide. Today's program is HIV Testing Update, New Regulations and Strategies from the Field. Our guests are Dr. Daniel Egan, an Associate Program Director and an Assistant Professor at St. Luke's Roosevelt Hospital Center. Debbie Lester, a Director at the Urban Health Plan, Inc., and Dr. Carrin Schottler, a section head of General Pediatrics at the Albany Medical Center. And thank you all for being here today. It's a pleasure to have you.
Thanks
Thank you for having us.
Dr. Egan, let's begin with you. Hospital emergency departments are one of the settings addressed in the amended public health law. Give our audience a feel for the emergency department at St. Luke's, if you will.
So I'm coming from St. Luke's Roosevelt, which is in Manhattan. We are a two-site hospital on the west side of Manhattan, relatively busy. We see at the St. Luke's campus more than 120,000 visits per year, and at Roosevelt a little over 70,000 patients per year. It's an affiliated teaching hospital of Columbia University, a level 1 trauma center. We have 40 full-time emergency medicine attendings and approximately 10 mid-level providers, physician assistants. And we're the site of an emergency medicine residency training 42 residents in emergency medicine.
And Dr. Schottler, the amended law requires offering an HIV test to all individuals aged 13 to 64. So the law clearly applies to pediatric settings. Tell us about your site.
Sure. Our office, if it's a very busy pediatric group, we have about 100 patients coming through our doors every day. We provide WellChild care from ages birth to 21 years. We're affiliated with the Albany Medical Center Hospital. We have 10 attending pediatricians, 1 nurse practitioner, and we are a teaching hospital. We have 30 residents who each spend a full day at the clinic every day of the week.
Thank you. Debbie, let's bring you into the discussion. As an outpatient primary care clinic, Urban Health Plan, Inc. has been working to implement routine HIV testing. Tell us about the scope of services provided by Urban Health.
Sure. Urban Health Plan is a network of federally qualified health centers located in the South Bronx and Corona, Queens. We have 4 health centers in the South Bronx, 1 in Corona, Queens. We also provide care in 6 school-based health clinics and 2 homeless shelters. We generate 250,000 visits annually, and over 50% of our patients prefer to speak in Spanish.
Dr. Egan, let's bring you back in here. Let's review the rationale for offering HIV testing as a routine part of medical care.
So, I think this is a multifaceted answer. So specifically in New York State, we know we have some data that's a little bit disheartening in terms of a public health problem. So we know that about 20% of people in New York who are HIV positive are not even aware that they're positive. And we also have this problem of patients not being diagnosed until they're already at the stage of having AIDS, and we call them late testers or late diagnoses. And about 1/3 of new infections that are diagnosed in New York State actually have AIDS at the time of their diagnosis. And so with that, we also have had significant advances in the technology of treating AIDS and the medications available. So there are a lot more medications available to get it under control, all of which we now know are beneficial the earlier that they're started. There's also some compelling data, mostly in different regions in the country, but particularly in South Carolina was one of the largest series represented, which was published in the MMWR a couple of years ago, where they looked at all of their new diagnoses of HIV over a period of 4 years, and they had a little over 4,000 of those patients. In their setting, more than 1/3 of those patients, about 1,800 of them, had AIDS at the time of their diagnosis. And we know based on this study that a lot of those patients, in fact, 77% of patients made visits to the emergency department, and in total, they had 8,000 visits to all healthcare providers. So they're seeing people not having the diagnosis made, and so we're identifying those as kind of missed opportunities for testing. This has been shown in emergency medicine data as well. Dr. White in California at Oakland, a very busy urban setting, also showed that people that they had diagnosed with HIV had been seen in their emergency department on multiple times in the years preceding their diagnosis. At my own center at St. Luke's Roosevelt in New York, I looked at all of our patients that had been diagnosed with HIV in our entire institution, both outpatient settings, inpatient settings, and the emergency department, and then tried to identify how often they had seen providers in our system as well. We have actually almost 60% of our patients have AIDS at the time of their diagnosis, so almost double what's quoted in the state. So we have a really significant burden of disease and also people who are very late testers. And of our patients who were diagnosed, about 60% of them had had contact with a provider in the years preceding their diagnosis in the 3 years, and 42% of those had been to the emergency department. And so I think it's, it's obvious that there's a need to identify more people and to try and get them found earlier.
And programs like this certainly help with that because we've made inroads, but we still have a great way to go.
Exactly.
Debbie, tell us about the initial challenges your facility experienced as you moved toward making HIV testing a routine part of medical care.
Sure. So one of our initial challenges was that for many, many years, we had a counselor-driven model, which basically means if a provider wanted to refer a patient for an HIV test, they would refer to a designated counselor. And our sites and providers were very used to that process, so getting them out of the mindset was a little challenging. In addition, that model very much limited the number of patients that could be tested. In addition, our busy community health center setting and our limited space were challenges that we needed to look at in planning the process out. And finally, our competing priorities and provider buy-in. At any given time, our providers are working on various quality improvement projects or making changes to their practice. So we didn't want this process to overburden them. We didn't want to make it complex. We wanted to really make it user-friendly and simple so that they would be able to implement it.
Now, I understand Urban Health Plan used its quality improvement infrastructure as a way to tackle the challenges of implementing HIV testing, right? Tell us more about this.
Yes, we did. Back in 2001, Urban Health Plan participated in a Bureau of Primary Health Care asthma performance improvement collaborative. And there we learned the quality improvement methods that we currently use today. One of those methods is the Plan, Do, Study, Act rapid improvement cycle. And basically the way that works is a quality improvement team thinks of an idea that they'd like to try to improve care, and they test it on a small scale first, learn from the process, and then build from there. Another key success strategy for us is we have a fully implemented electronic health record since 2006. This allowed us to basically place the HIV test offer and the HIV testing into the electronic health record system, acting as prompts for the provider and allowing us to document and also report out on our measures. I guess finally, we put together an expert panel that would be an internal experts to actually plan the process out very, very well before we started.
Now, tell us about the expert panel. How was it comprised? Who comprised this expert panel?
Well, we thought it was very important to have our senior leaders on the panel. They're the ones that drive improvement at our organization. We also included the Chief Technology Officer, the Clinical Systems Administrator who's in charge of our electronic health record, the Director of Nursing, our Section Head of Adult Medicine who's also an infectious disease specialist, and myself.
Terrific. Now, an integral part of quality improvement is having clear measures. What were the measures Urban Health Plan used and how were they established?
I'm going to talk to you about the measures in a second. I just wanted to discuss the work that the expert panel performed.
Sure.
So, because they were our planning body.
Yes.
So what we did was, first we studied the new HIV testing legislation very carefully to make sure we understood it. We also engaged an AIDS Institute trainer to help us understand the legislation, and we consulted with this person throughout the process. We developed a team structure, which I'm going to talk about in a moment, and we hired an HIV testing coordinator. We also developed protocols in the form of flowcharts so that we could really map out exactly how we thought this process would work best at all of our sites. And the flowcharts are great because not only can you identify gaps in the process by using them and see how the flow would really work, but we also used them as training tools. Once we kicked off the quality improvement teams, we used the flowcharts to teach them. And we drafted policies and procedures. We created fields in the electronic health record to capture and report on the measures. And as far as the measures go, we actually decided that our measure would be that 90% of patients ages 13 through 64 would have an HIV test offer. And we chose 40% of our patients ages 13 through 64 would have an HIV test. The reason that we chose 40% was because when we calculated our baseline, we were only at 8%. So we realized that actually 40% would be a good stretch goal for us.
Okay, and so walk us through the HIV testing offer as well as the protocol.
Sure. So this is a brief description of the protocol. Basically, the medical assistant checks the practice alerts in the electronic health record. Then they educate the patients on the key points of information which is required. The provider can then see that the HIV test was offered as they see the patient, so it reminds them. They verify with the patient that they would like the HIV test, and of course if they agree to it, they will document the order of the test, and also if they refuse, they document the refusal. And then finally, during the discharge process, the patient is given, let know that they can come in for their results on a walk-in basis, or they can get their test results at the next visit.
And what about the testing team?
So the testing team were the key players in our process. Once the expert panel worked out the details of how we would like the HIV testing to be implemented, the testing team were the people on the ground that would try out the process. So the way we did this was we took each of our sites and each of our major departments, and each had its own testing team. And that testing team had a provider champion, a medical assistant, and the site director or departmental director. We brought these teams together and we basically trained them on quality improvement, we trained them on the HIV testing legislation, and we trained them on the protocols that we were proposing. We also shared baseline data with them, so they were able to see where they were starting, not only site-specific and provider-specific data. So each provider saw their own data, and all the providers saw each other's data. So that was actually really kind of a good process, because when the providers saw the data at the kickoff, they were very excited about the data, and they kind of wanted to improve it. And after we trained them, we had 4 meetings, 4 weeks in a row. We had a team meeting, a 1-hour team meeting, and during those meetings, they came back to us and told us how it was going, told us what was wrong, told us what was right, and then we also, during those meetings, gave them their weekly data so they could see how they were doing along the way. Also, we scheduled a learning session, so 4 weeks after the kickoff, the learning session is so that the teams can report to the senior leaders on how they're doing and also get feedback from the senior leaders.
This was an extremely multifaceted, comprehensive approach that was taken. A cornerstone of quality improvement is active involvement of the team in the process. This involves getting feedback, which sounds like that was an essential part of what the team did with you, but how things are going and providing the team with regular updates, as you just talked about. Can you give us more information about that?
Sure. So yeah, it was a really good process, because having these weekly team meetings allowed the providers and the MAs, medical assistants, to tell us how they really felt about the process. And actually they gave us some very good feedback. One of the first things they said to us was there were too many clicks in the system to actually do the HIV test offer and the HIV test. They wanted us to minimize those clicks. So we listened to them and we actually were able to do that. Also, we coached along the way, so we were analyzing the data behind the scenes, seeing which providers and medical assistants were, getting it, which maybe needed a little bit more help, and we were providing targeted coaching. We also provided accurate feedback data to the providers, and this kind of became an interesting issue because some of the providers weren't convinced the data was accurate. One provider in particular, said, I know I offer every single patient the HIV test, and it didn't look like that in the data. So we went back and checked and made sure that we were doing it properly, and actually she was right. We did find a little glitch with the data, so we ran the data again, double-checked it, showed the providers the new data, and they were very happy because it was accurate and something that they could use to inform themselves and drive the improvement. And I guess the last thing that we did was, one of the feedbacks we got was some of the providers weren't completely comfortable giving a positive result. So we brought in an expert, an AIDS Institute expert, to train them on that. And we also provided some support. When we knew a patient was coming in to get their results and they were going to be positive, we provided a social worker on standby.
Terrific, terrific. Let's take a look and review some of the data from the project.
Sure. So this is our organization-wide graph. It shows, as you can see from the graph, our baseline was about 8%, and the light blue line represents our HIV test offer, which through the PDSA process, through the teamwork process, went up to about an 85% HIV test offer rate. And the HIV test itself went to about a 52% testing rate.
Debbie, a requirement of the amended HIV testing law is arranging for HIV care for patients with confirmed positive test results. Tell us about how that worked at your facility, the Urban Health Plan.
Sure. Our HIV testing coordinator tracks every single HIV positive patient to make sure they to get their results and get into HIV primary care. So 98% of our patients have received a primary care appointment. And of those, 76% kept their first appointment. So we tracked them through their first or second appointment. In addition, we were pretty pleased with the process because routine HIV testing allowed us not only to identify new positives, but also we found that there were patients that had been disengaged from care. They knew they were positive but hadn't been in care for a while. And we were able to use this process to get them back into care.
Debbie, share with us some of the lessons learned from the process.
Well, I think the big lesson for us is that the planning up front was really important and it was well worth the time to do it. This planning body really mapped everything out, and I think that helped us be pretty successful. Also, the senior leader endorsement of the project. I mean, all of our quality improvement projects, we always have that senior leader saying, yes, this is important, and I think that's really, really crucial. Also, the building of the momentum, the weekly team meetings and the weekly data graphs really kept people going and interested. I think people were actually looking for their data, wondering how they were doing, and that built momentum. Incorporating the testing team feedback was really important, and knowing that them seeing that we did incorporate their feedback was important. And then finally institutionalizing the process through finalization of policies and procedures and adding these data elements into our clinical dashboard.
Very impressive work with the Urban Health Plan, and thanks so much for sharing that with us today. Dr. Schottler, let's turn our attention now to how to integrate HIV testing in the pediatric care setting. Tell us about the structure of your practice.
Sure. Along with the physicians, we have other very important members of our team, our nursing staff. We have one on-site nurse manager, 4 registered nurses, 2 licensed practical nurses, 3 medical assistants, and our very essential clerical staff up front.
And Dr. Schottler, I understand that your practice of offering HIV as well as STI screening to young people has evolved over the years. Tell us about this evolution.
Yeah, it's a very interesting evolution. Pre-2005, adolescent physicals in our office were given the same amount of time as other age physicals, 24-month physical, 3-year physical. All physicians were instructed to ask about sexual activity and risk-taking behavior with our adolescents, but we never really had a standardized form on which we could use. HIV testing at that time was done via blood draws. Most patients were instructed to go out of the office and get their testing done out of the office. HIV pre and post testing was done in the office, and it was done by providers, and usually post testing was done after at another day. Urines were sent for gonorrhea and chlamydia, and that was just beginning to get done, but we really had no formal office flow on which to do that.
And what about the protocol for adolescent WellChild care visits?
Yeah, we had a very interesting protocol. We didn't really have a protocol pre-2005, but in 2005 we started developing our own adolescent WellChild exam protocol. And what we really wanted to do is get parents on board with it. That was our biggest concern. So at the 11-year physical, before the 12-year physical, which we consider an adolescent physical, we started talking to parents in the exam room about what would happen at the next 12-year physical. We wanted to share with parents what we would be doing, that we would probably be asking them to leave the room, to prepare them and give them a year in advance to talk to their adolescent about it. And then we started, before we started the protocol, we started sending letters out explaining the protocol to the parents before their 12-year physical. And then in 2005, we started it. When the adolescent was checked in for their 12-year physical, the nurse explained what was going to happen to them. And we found that our nurses found it very, very helpful to have a script that they all could use so that they remain consistent in their message to parents and adolescents. They instructed the parent that the child would be given a questionnaire to fill out, and the nurse also explains that the doctor will meet with the adolescent alone before the parent is allowed in the room. And then the nurse then told the parent to wait in the waiting room, and the doctor would get them when they were done. While the nurse was checking the adolescent in, she explains how to collect the urine specimen and send the adolescent to the bathroom to do that. And then the adolescent was given time to fill in our questionnaire, and the doctor entered after the questionnaire was finished.
Now, you just mentioned the parent being asked to wait outside in the waiting room. Have there ever been instances where the parent expresses concern about not being in the same space with their child and the provider during the screening process?
Oh yes, and I understand them, especially if they haven't met the provider before. So if that was a concern to the parent, the nurse was instructed to let the doctor know, and the doctor would meet the parent beforehand and explain the protocol to them.
Okay, so certainly calming
them down.
Calming them down.
Calming them down.
Yes.
And then the doctor would go in the room, review the questionnaire with the patient, and by the answers on the questionnaire and the answers that the adolescent would provide us, we would send the urine for gonorrhea and chlamydia, depending on their risk. We would discuss STD testing with the adolescent. HIV testing was offered if they thought the patient may be at risk. And pre-testing was done, and a script was given for an HIV test. Hepatitis C testing and RPR testing was also included with that. At that time, the patient was really on their own to get the testing done off-site, and post-test counseling was done then at a follow-up visit.
Can you tell us about the questionnaire that's used in your office?
Yeah, it's a questionnaire that we have amended over the years. We've amended it for several reasons. One of the reasons has been for adolescents to understand it better. We really want to make sure we take health literacy in mind when we give this questionnaire out. We also wanted to make sure we always improve the quality of care. With the new HIV law, we wanted to make sure, and we amended the questionnaire at one point to make sure that we added, if they wanted to get a HIV test done, we added that question in. Some of the things in the questionnaire, we deal with very benign questions in the questionnaire, questions about their diet, questions about exercise, and then later on in the questionnaire we get into the really big stuff, STDs, really we call it sex, drugs, and rock and roll type questionnaires, questions. And we get into that stuff and we have them fill that out as well. A key component of our questionnaire is asking the teenager for their cell phone number. Nowadays, most teenagers have their own cell phones, and if we ever have confidential information we need to give to the teenager, we can do it by their own cell phone.
And I understand as recently as 2009, you were still dealing with issues pertaining to patient compliance. Can you talk about that?
Yeah, it was very frustrating. We had an awesome questionnaire and we got a lot of information from our adolescents, but we were really frustrated because it was really difficult to get adolescents to follow through with a lot of the testing. Even if the testing was done off-site, it was very difficult then to get them back in to do post-test counseling. And adolescents are sometimes very reluctant about blood draws, and the minute they heard about a blood draw, they just tuned us out. So in March 2009, we developed a team with Albany Med Pediatrics, Albany Med Infectious Disease, our laboratory at Albany Med, and HIV counselors to discuss rapid testing to be done at Albany Med.
Okay, rapid testing.
Mm-hmm.
I've heard about rapid testing. Can you tell us about that? What is that? What is that term? What does that mean?
Rapid testing is needle-free. It's actually done by swabbing the buccal mucosa of the patient. It takes about 20 minutes to get the results. It is a screening test, so we do have to do confirmatory testing afterwards if it is positive. But it's really been very helpful, especially for those needle-afraid adolescents. So to tell you a little bit about the story about implementing rapid HIV testing, it was originally grant funded. We had an employed counselor, HIV counselor, we had a social worker, and we purchased test kits. The testing team had one session a week where they offered evening appointments to adolescents to get testing done. We really had to advertise a lot to our adolescents about this testing process. We put signs up in the exam rooms. Providers, if they did notice that the patient may be at risk during the visit, would explain to them about this session. Appointments were scheduled by the front staff. Appointments for testing were not charged to the patient. And if a positive test was done, if a positive test turned out, a confirmatory blood test needed to occur the next day and could be ordered by the MD present during evening hours. And when the social worker employed by the grant then would arrange to meet with the patient at the off-site lab and arrange follow-up as needed.
Was the entire staff involved in this?
The entire staff was involved with this. However, we noticed that only one session a week really wasn't enough. And my nurses became very, very proactive and decided, why can't we offer this all the time, and why can't we get trained to do it? So they loved having it. We always want to make things better for our patients, especially adolescents who may need a little bit more hand-holding, and the nurses stepped up to the plate and became involved.
And despite how things have changed, are there still barriers that exist?
There are. First of all, just to let you know what our nurses did, our nurses were trained how to conduct HIV testing. Medical assistants were trained on key points on HIV testing, and we offered HIV testing any time of day. We reached out to adolescents during their well visits. Providers could leave, and we could have pre and post testing done by medical assistants and nurses, and our social worker was still on call for any positive results. But there are still barriers. Payment, our grant ended, but we're still able to bill for the test. We bill it under viral testing. We still have continued concern about patient confidentiality, especially when explanation of benefit forms are sent home to the patient. The test takes 20 minutes. Parents can become very curious if they're waiting in the waiting room for 20 minutes while their adolescent is getting this test done. And we currently still have to tweak patient flow. We are very, very busy, and we do have to make sure that our staff have enough time so that they can do pre and post counseling with the adolescent.
Dr. Schottler, thank you so much for sharing this story with us. And based upon your experience and the lessons learned from them, can you share with us what other pediatric providers should know and be aware of?
Yeah, we do have a lot of lessons that we've learned. First of all offices can evolve. You can do something about adolescent compliance, especially when you have a captive audience. We had great big ideas, but we really had to take small steps, as you saw from the story that I presented. And it's good to critique a plan. And at first, we had a lot of critiques about having an HIV counselor there just one day a week. But you have to start somewhere, and you can't suffer from what I call analysis paralysis. You got to start and do something. And never underestimate the power of your nurses. They really want to become involved, and they're wonderful patient advocates.
Thank you so much. Dr. Egan, I'd imagine that there has been an evolution of ideas and practices around offering HIV testing in the emergency department. Give us an overview.
So you're exactly right. So it's changed, and it started actually back in 2006. So the first time that we even heard the concept of HIV testing in the emergency department was from the CDC in September of 2006, when they published recommendations essentially strongly recommending that HIV testing be offered in the emergency department, particularly in areas where there's an undiagnosed prevalence of greater than 0.1%. And so in many regions in the country, that's what it is. And so this recommendation was put forth, and I think a lot of it came from data similar to what I mentioned before in South Carolina, where there are multiple people seeing seeing providers in the emergency department with undiagnosed HIV and having multiple encounters with those providers. The other thing that they recommended at that time was that patients who are getting evaluated for sexually transmitted infections should also be tested for HIV, which makes sense. And I think the biggest change in 2006 was that they wanted the framework of testing to change from an opt-in test to an opt-out test, essentially meaning that someone can come in and, as part of their general consent for treatment, be informed that an HIV test is going to be done today only unless you opt out of the test, as opposed to having a separate barrier that requires them to opt in for the test with more formalized discussion, kind of adding to the whole stigma of HIV. About a year later, the American College of Emergency Physicians changed or released a policy statement, I think taking into account the compelling data of visits to the emergency department and coming on board and saying that HIV testing is an important thing. And you'll see on the slide the actual quote of the policy, but basically embracing this concept that this is an important public health measure that should take place in the emergency department. And it should happen in the same way that we provide efficient and expeditious results to other tests. And it makes sense for the emergency department because the patients who we know are at most risk for HIV, those who are marginalized from society, who don't have great access to primary care, who are underinsured, who are underrepresented minorities, those are the people that we take care of. And in many larger urban settings, we provide primary care services to these people. So we really are that safety net where people can go when they don't have another place to go. And these are the people who are at risk. And so the ED is an ideal place to provide that testing. So that was in 2007. And then in 2010, the main reason that we're here today, New York State passed a legislation. And as part of the legislation for HIV testing, it requires now that all patients who come to the emergency department between 13 and 64, as well as all the other healthcare settings that we're hearing about, be offered an HIV test. And this was explicitly stated that it includes the emergency department. So now it's not really a choice anymore, and people really need to embrace this and figure out ways, which is part of the reason we're here, to develop programs to offer testing in the department.
I understand you have some case studies to share with us today.
Yeah, I think it's helpful to just give kind of real examples of people. These are just two patients that I saw, to just emphasize the reason that this is important. So the first case was an adolescent, like we've heard about. So someone I saw on a shift in the pediatric emergency department, an 18-year-old that had been to the ED several times and had come in thinking that he had a hemorrhoid. But it turns out actually that he had several abscesses in his perirectal area. And so in interviewing him, I assessed risk because it was just a little bit of a red flag to me, and he said, I'm negative, I was tested a year ago. And when I asked him about his risk profile, he really denied anything. So I offered an HIV test, and I said, if we're not worried, we might as well just get one today. And he agreed. And so his rapid test was positive. And then on further questioning, it actually turns out that he says, well, sometimes I do use crystal meth around the time of sexual activity, and I don't always have safe sex. And so really the information he gave up front was not actually truthful, which I think probably you see a lot in adolescent medicine where they're not forthcoming right away. And so if that had been a targeted test, we would have missed that opportunity. I think the second case is even more compelling, which was a 52-year-old woman that I saw who was from Yemen, who didn't speak any English. So my entire history was through the interpreter phone. And she was in a full burqa, a very traditional Muslim woman. And she had come in with shortness of breath. And on her exam, it was suspicious for pneumonia. Her oxygen level was low. And when I got an x-ray, it looked like PCP, which, as we know, is an AIDS-associated illness. And so when I went back to talk to her again through the interpreter phone and ask her about risk factors, she was very emphatic. I'm Muslim. I'm in a monogamous relationship with my husband. There's no way. And I encouraged her to get a test, and she agreed to get a test, and her test was positive. And so while she may have been monogamous, it seems as though her partner was not necessarily being monogamous. And so I think this just illustrates nobody would really picture this woman as being at risk. And so she came in, and while we missed the opportunity in triage for just routine testing, we were able to test her. And I think, she's been positive for 8 or 10 years at that point, and so likely has been to the doctor and just never either perceived a risk, and so never opted in, or just was never offered one. We're not sure.
Thank you for sharing those. And, clearly the emergency department can be a busy, challenging place. And I don't have to tell you about that. That's something you're experiencing just about every single day. Tell us, how did the emergency department staff handle the notion of being required to offer HIV testing?
So you can imagine there's resistance. In my place, we had testing before the law, but I've talked to a lot of people who deal with this sudden need to implement testing. But even when we were doing it before the law, there was clearly resistance. So many people don't think this is an emergency, and so is it really worth the efforts to do this public health measure for potentially a small portion of our patient population? And so not everybody agrees with that principle of public health in the ED, since we're supposed to be dealing with more emergent cases. We're already so busy, and we're already under the regulations of a lot of outside agencies for patients in the emergency department, which are set forth by people who don't do our job every day. So things that we have to do that don't always make sense from our perspective that we are forced to do by outside regulators. And so there's already that kind of frustration factor. I love the expression competing priorities. I think that's a really good way to capture what we all face every day. And when I'm on shift and busy and taking care of someone, with an MI or an acute stroke or a stab victim, the last thing I'm thinking about is offering HIV testing, and I think that is a competing priority. So, so everybody's busy. They've got a lot of other things going on. And then my environment, we see HIV and AIDS, but not everybody does. And so people don't always think that we have enough HIV positive patients that this is a worthwhile endeavor. And then they're not comfortable asking about it. They're not, in many environments, there's still a stigma attached to talking about HIV. And so there's not a comfort level in talking about the test, And then even more so, there's not a comfort level in delivering positive results. And that's, I think, often the biggest barrier, although my response to that is always that for a living we deliver bad news. We routinely tell people that their closest family member has passed away, or deliver horribly unexpected news of a new malignancy or some metastatic process that nobody's expecting when they come into the emergency department, and we do it all the time. HIV no longer carries with it that same prognosis that a lot of those other things do. And so this is, my analogy is this is like diabetes and hypertension in many ways now. Your life is absolutely going to change, but with medication and those things, you're going to have a normal life expectancy. And so the news is actually not as hard to deliver, I think, than some of the other things that we do.
Absolutely. What were some of the key elements that emergency departments have to consider as they develop a model for offering HIV testing in accordance with the public health law, Dr. Egan?
So I think it's like we've heard from the other practice settings, it's all about the planning. So it's all about how are you going to design a program that's effective for the environment in which you work. So one of the very first questions is who's going to ask? So is it going to be the nurse in triage where a lot of the questions take place so it seems like a natural environment? Or is it going to be the provider? Many places have trouble, and there's a lot of literature to support that provider-initiated testing doesn't work because we're distracted. I'm distracted, and I'm sort of the biggest champion of HIV testing. And then after it's offered, who's actually going to do it? Is it going to be the nurse? Is it going to be the provider? Are you going to have an outside counselor, which may require additional funding? Or are you going to use existing staff? We use our ED technicians who do all of our point-of-care testing. It needs to be somebody who has the ability to go to the patient's bedside and then also has that time interval where they can read the results within the allotted time frame if you're using a rapid model within your department, not sent to the lab. And then there's issues of training. And with the training, what kind of testing you're doing. So are you going to use the oral swab, which is what we use, and I think very easy for a quick turnaround and ease of patient acceptance. But some of the rapid tests use finger sticks to obtain a blood sample. And then you could make an agreement with your lab that you're going to send blood tests to the lab for testing. So there are many different models. And then once you've done the test, then there's the issue of how do you deliver the results. So confidentiality is key here, and it's difficult in many emergency departments to ensure an environment of privacy. Many of our rooms are just separated by a curtain, which is not really fair to the person who may be receiving this news of a positive result. So how do you do that, and how do you keep it private and provide an environment for the patient that's a safe place to hear this news? And then there's the logistics of ordering supplies and turnover and maintaining the kits and providing and doing the quality improvement. And then I think the biggest element of this, which is required ahead of time for planning, is what's the linkage to care and follow-up plan, which for every emergency department is the hugest challenge in our job, to be able to contact a person after they've left, whether they've given you the wrong phone number or you don't have accurate information, to find them and then to assure that they're going to get follow-up care regarding their HIV test.
Who are some of the key players involved?
So I think it's similar to what we've heard, and there are key players in every practice environment. So clearly nursing leadership needs to be on board with this, especially if you're going to ask your triage nurses to be involved in the process. The physician leadership, your staff needs to believe this is important and to want to do this and to provide this service. There needs to be somebody who's the champion, and so I use that word because I think it's true. And I guess I'm the ED champion at my place, and it doesn't mean that I do more tests than anybody, but I believe in it and I talk about it and I remind people of it. And I think somebody needs to take that on as kind of their project. The lab, most institutions have clear point-of-care testing rules and regulatory mechanisms and QI processes that need to take place. And you need to have the involvement of the lab if you're going to be doing a testing procedure, and sort of to make sure that you're following the procedures that are required by your institution's own policies and procedures. Social work is incredibly helpful, and so their ability to deliver bad news and to spend time with patients and to really sit down and not necessarily need to move on to the next person who's waiting or to get called out of the room because someone more critical has come in, they can be just an amazing ally. And then the colleagues to whom you're going to refer your patients. So you need to involve your HIV or ID colleagues. And if you're at a place in a more rural setting where you don't have those people right on site, you need to identify who in your region are the providers who are able to accept patients into their practice as their follow-up if they do test positive.
And Debbie, as well as Dr. Schottler, spoke about barriers specific to their settings. What are some of the barriers that you're seeing specific to the law?
So I think many of these barriers can be overcome, and they all can be overcome, but it's about the planning mechanism. So documentation's always an issue. And so depending on your system, many people are still writing charts handwritten, and there are multiple things that need to be documented in the record: the consent, the results, the patient informed, and the fact that you followed all the steps that are required by the law. And so I think that plus the delivery of the key points is challenging. So you can have them done verbally, you can have them on paper. The state has amazing posters that you can hang and laminate in your setting, or if you're actually going to give patients something to read. And then the linkage to care is really the biggest challenge.
Now, Dr. Egan, I really want to talk a little bit about follow-up. You've underscored the importance of follow-up, and when a person goes to the emergency departments, it's typically for one visit. They don't usually return unless there's another emergent concern. So how does follow-up work with regards to HIV test results, making appointments for HIV care, et cetera?
Yeah, so I think this is one of the biggest challenges in the law, because it's not, the law specifically says that you can't just refer. So you actually have to secure an appointment for someone for follow-up care. And so for us, it's actually having a place where you can identify a location where a patient can go and they can leave with a date and a time that they can be there. And so that's a tough thing. It's not, it will likely need to involve other members of your staff, whether it's your clerical staff. Social work is amazing at this kind of thing. And so it needs to happen before they leave. There is the stipulation that since the emergency department's a 24-hour operation, that if the test result takes place off hours, that process can happen the next day to secure a specific appointment. And like I said, this is something that really just can't be done alone. It needs to be a collaborative effort with, if you have HIV providers at your institution, then they need to be involved with this, or a referral center to which you can send your patients.
So tell us, how were you able to operationalize HIV testing in your emergency department?
So we've decided on the rapid model, and I think in our setting that works best, because people like to get answers, and giving people results before they leave is the best mechanism in the emergency department. So anybody who arrives, the triage nurse essentially asks a patient, says, we offer HIV testing to everyone that comes in. Would you like an HIV test today? And when that happens, the key points are, we have them displayed on posters in the triage room, so that's available for them to see, so that they can receive that information. When this happens, it automatically flags our electronic medical records so that the provider sees that there's a patient who'd like to have an HIV test, and that prompts them to go and obtain verbal consent. Once they do that, they document that in the record, and that flags our technicians to go and perform the test. And they do the test, and the protocol that we've established is that if it's negative, they can just enter that into the electronic record, and we can see that. If it's a positive, they need to verbally communicate that with the provider so that we are obviously aware. And we have, obviously the patient is informed, and then everyone receives written discharge instructions that say positive, prelim positive, or a negative result. And we have it linked with our electronic system so that it automatically defaults into the discharge instruction section of our chart, which is helpful for compliance measures as well. The positives are the biggest issue, and so everybody gets nervous, and how do you bring that into your routinization of the practice? So we have a wonderfully comprehensive center for HIV at our institution, and during the day, we can page their social worker who has a 5-minute response time, and they come and help us deliver the news. And off hours, we essentially have a pre-made packet of information that we provide to patients. We call it our positive packet. We don't tell them that's what it's called, but and we give them all that information, and then next day we reach out to them via a daily report that takes place from our electronic system, and the social workers in the HIV center will find them.
And what about suggestions for other emergency departments for success?
So I think it's helpful to tell the stories. I think when I can give feedback to a particular nurse that they offered this person a test and we found them and we've now changed their life and have informed them of their status, it's a very powerful message. Or the young and the old. I think people respond very sensitively to those diagnoses because it's not something expected. Show them the evidence that it works. I think the reports, the feedback, those are all key elements. Keeping your staff informed of what the changes are and how they're doing, and providing numbers and quality improvement measures. And I think as a department, incorporating this into your routine measures of QI. So everybody has QI meetings. We all have core measures that we have to follow. We all have standards we need to meet. And I think if this is just part of that, since it's now legislation and regulation, that it just helps to make it more streamlined and use your information technology to your advantage. If you're in a busy place, which everybody's busy these days, having the ability to use your computer system or your electronic record to facilitate this process and minimize paper and barriers in terms of obtaining different pieces of paper, I think just maximizes efficiency.
We're coming to the end of our time together today. Dr. Egan, let's wrap up with you providing us with some key take-home messages.
So first of all, this is a feasible thing. It can happen. And there's lots and lots of literature out there for emergency providers who are trying to find out how to do this with different models, success models, even in really busy places. It does require the buy-in of your staff members, though, and so people need to believe that this is important and to take part in the mission. And it can't happen if it's not a team process and involving teamwork and collaboration of multi-specialties as well as the different levels of care providers in the emergency department. The positives happen infrequently, and so while people are so nervous about those, it really doesn't happen as often as we think. And there are a lot of resources available through the AIDS Institute and through other people who've done this to help you in the process of setting up your program.
Thank you, Dr. Egan.
Yeah.
And Debbie, are there key take-home messages based upon your experiences with the urban health care plan, urban health plan that you can share with our audience today?
Yeah, we have a few take-home messages. One of them would be to use the quality improvement structure. Not everybody goes in this direction, but we feel it's a really effective way of doing the work. A lot of people are nervous about doing this work still, so if you do it as a quality improvement team, that team works out the kinks. And then you can spread the process, and it takes away some of the anxiety, I think, as well. It's a great process. The other thing is senior leader endorsement is just key. I think providers and medical assistants, they need to see that the senior leaders are on board and they're actually asking us to do this work. The EHR is a wonderful tool. The prompts, the ability to be able to see the HIV test offer and the provider to see that and remember, okay, let me talk to this patient about an HIV test. It really works out very well. I think for us, the whole quality improvement team structure created like a healthy competition amongst the providers. Getting their data every week and seeing how they're doing kind of drove improvement and drove excitement into the process.
Thank you so much. Sure. Dr. Schottler, closing remarks from you in terms of take-home messages.
Yeah, I think to remember that adolescents are at risk. And rapid screening is really helpful, especially with adolescent compliance. I think it's so important to establish the practice of provider and adolescent meeting alone without the parent, and establish that early on. Adolescent questionnaires have been so helpful in our practice, and we've gotten a lot of information from adolescents this way. And train your nurses and your medical assistants to really help with your process.
Well, Dr. Schottler, Debbie, Lasker, and Dr. Egan, I want to adopt your word. You're all champions, and you're not only champions in your specific settings, but you're global warriors in terms of the very important work that you're doing, and it's been such an honor to have you here today. Thank you so much.
Thank you.
Thank you. At this point, we will wrap up the broadcast by hearing about the toolkit that Daniel O'Connell referenced at the beginning of this webcast. But first, thank you very much for joining us today, and please remember to fill out your evaluations online. Your feedback is always helpful to the development of our programs, and continuing education credits are available. To obtain nurse continuing education hours, CME and CHES credits, learners must visit www.phlive.org and complete an evaluation and the post-test for today's offering. As a reminder, you can also download the companion guide to this broadcast on our website, phlive.org. The companion guide will provide you with learning activities to help further your knowledge and understanding of topics covered in today's program. An archive of this webcast will be on our website within 2 weeks. Please join us on June 21st for the next broadcast of Public Health Live on the rising number of adults living with Alzheimer's. I'm Joy L. Ray Alexander, and thanks for joining us on Public Health Live. Now, as mentioned previously, Here's more information on the HIV Toolkit from Daniel O'Connell, who had talked about it earlier.
Toolkit is intended to be an easy-to-use, one-stop resource for implementing routine HIV testing. The toolkit includes numerous documents saved together in PDF format. The first page of the toolkit is a table of contents that describes what you'll find in each section. You can easily navigate within the PDF by going to the gray column on the left and clicking on the second icon that looks like a ribbon. This will open the bookmarks to each of the sections of the toolkit. Section 1 provides an overview of the law, including the specific settings and providers affected, and reviews the simplified informed consent process. The overview provides the key points a patient must receive before testing and offers recommendations for HIV testing among young people aged 13 to 18. Strategies for delivering a post-test negative result and important HIV prevention resources are also outlined. Section 2 of the toolkit provides detailed follow-up actions for patients with a confirmed HIV-positive test result. It outlines what should be covered in post-test counseling, the requirement to arrange follow-up HIV care, and it reviews case reporting requirements and issues related to partner notification. Section 3 provides a summary of HIV testing in the context of occupational exposure. Sections 4, 5, 6, and 7 are print-ready PDFs of patient brochures, clinic posters, and a handout with information for parents about HIV testing of minors. Section 8 of the toolkit provides additional information about the simplified consent process for HIV testing, including information about oral consent when offering a rapid screening, incorporating HIV testing into the general medical consent form, and PDFs of model consent forms. Section 9 includes PDFs of 2 different forms that are used to authorize the release of HIV-related information. A technical assistance document that provides guidance about the appropriate use of these forms is also included. Section 10 is a coding guide from the American Medical Association that lists Medicare, CPD, and ICD-9 codes to facilitate appropriate billing for HIV testing services. Finally, Section 11 is a list of additional resources, including links to the Health Department's HIV Testing Frequently Asked Questions document, a list of HIV care providers to facilitate making appointments for HIV Care, a link to HIV clinical guidelines, training resources, and other important links and resources. The Health Department hopes this toolkit will facilitate the routine offering of HIV testing. Any comments about the toolkit can be sent to hivtestlaw@health.state.ny.us. The toolkit is available on the DOH website.